Well, good morning, everyone. This morning's topic was going to be hypothermic coagulopathy. This was kind of a presentation we did with the Banff Wilderness Care Conference last year, and I think we did it at the Expo as well. So I just thought it was something we could to bring out to the rest of EMS. So moving on, just about me, like Ryan said, I'm a paramedic out in Banff. Been out here for about 14 years. My interest kind of into wilderness medicine has been the last kind of 4 or 5 years as I completed my diploma in Mount Medicine and just finished up a fellowship with the Academy of Wilderness Medicine. And it's really where this kind of topic has come through in the wilderness medicine world and in the military worlds. They've been really kind of pushing this topic, and I think we'll see a little bit more on it as I'll get into in the future. So moving on, disclosures. Obviously, I have no financial conflicts of interest. I am a member of the Wilderness Medical Society with that diploma and fellowship, so there are some of their policies and kind of ideas that are in here that may differ from other sites, but you know, like anything in medicine, there's a few different opinions, but this is the people that I kind of go to. But moving on, I mean, really what we want to do is look at the issue of trauma in the austere environment, and obviously we have some, and austere environment can be just the back of the ambulance because we are, you know, away from resources and then that type of thing when it comes to hyperthermia and treatment. Okay, so typically when we think hyperthermia, this is what we think of, right? You know, the scene from Titanic, or flip to the next one there, Ryan. You know, the urban outdoorsman, or the next slide there, Ryan. And if I'm sure you're most familiar with this if you have kids. So we think of, you know, just people getting cold and being exposed to the environment. So we'll flip to the next one there, Ryan. Anna Bragenholm is kind of one of those typical cases. I'm not sure if anyone's familiar with her, but she was out skiing, touring, and she fell through a creek, the ice on a creek, and fell into the creek. Her head was exposed, but she was down quite a ways, and they couldn't get her out, so they had to ski out to get rescue. The rest of her body was laying in the creek, which quickly cooled off. She became unconscious after about 40 minutes. The rest of her party lost contact with her after about 40 minutes of being in the hole. And 40 minutes later, she was extricated out of the creek. She was lifeless, asystolic, where they started CPR. They had a 1-hour flight to the hospital. So in total, she had about 130 minutes downtime with 90 minutes of CPR. And the lowest core temperature they recorded was 13.7 degrees. She was in ventricular fibrillation for about 10 minutes before spontaneously converting while she was on bypass. She spent 21 days in the ICU, or sorry, 28 days in the ICU, and was finally discharged. And kind of surprisingly, at the time, she was a resident. I believe she was in orthopedics, and when she went back to finish her schooling and to work, she actually went back as a radiologist, so it appears she got smarter after this incident. But she's still around and doing just fine after this kind of amazing survival story and long CPR period of CPR. We also have a Canadian example where there was a young lady about 2 years ago in the Squamish area that also had a cardiac arrest due to hyperthermia, where she received over 4 hours worth of CPR and survived neurologically intact, and still talks to the rescue team. So that's, you know, we have some amazing cases of hyperthermia protecting people and helping them survive certain situations. So throughout history, numerous sightings and documents have demonstrated that hypothermia has been seen as a treatment for sick patients. Hippocrates advocated packing wounded soldiers in ice and snow. Napoleonic war surgeons noted how officers who were kept beside the fire and inside and warm seemed to have actually worse outcomes versus the soldiers who were left out in the snow. During the 1950s, we saw our first applications in modern medicine during brain surgeries. And then in the 80s, they started playing around more and more with hyperthermia and in surgeries to help protect the patients as they were going through this. They also found that during this time they demonstrated in dogs that hypothermia had a positive effect after brain ischemia, so after strokes. And in 2002, we know the two studies out of Europe and Australia published positive effects of mild hypothermia applied following cardiac arrest, which led to the Yale Corps and AHA recommendations of hypothermia after cardiac arrest. Right? And since then, a number of studies have demonstrated positive effects of hypothermia following strokes and burst asphyxia and other things. So primary hypothermia definitions. This is based on the WMS definitions, but cold stress, we know it's kind of anything above 35 degrees Celsius. You start getting a little chilled, you start feeling cold, you're looking for extra coats and blankets and stuff. And it's a lot of our patients that we'll see. Mild hypothermia is from 35 to 32 degrees Celsius. Moderate hypothermia from 32 to 28. And severe and profound hypothermia is less than 28. Sorry, Ryan, there was a slide for that one. If you wanted to flip to the primary hypothermia definition.
Yeah, I'm there.
Okay. So as you can see, yeah, so cold stress is above 35, mild hypothermia 32 to 35, moderate hypothermia 28 to 32, and severe or profound is less than 28. So there are going to be definitions for what the core temperature is of someone suffering from hypothermia and where we're going to put them into kind of different categories. And is our kind of traditional definition of primary accidental hypothermia. So as we started using hypothermia in modern medicine, the surgeons noticed that there actually was increased rates of surgical bleeding, which kind of brought up some interesting ideas. Now, as we move forward, I'm just going to give you a bit of a kind of a case study to keep in the back of your mind on how you treat this patient. This is a guy we actually saw in Banff here, but he was a fellow who was working up on one of the local mountains doing some work on the hydro lines. So he's a 34, 35-year-old guy who basically zip-lined down a power line and injured himself. He ended up with bilateral femur fractures. The left is closed, the right is open. He had a stable pelvis fracture, ruptured spleen, and a basal skull fracture. So I just want everyone to think, kind of, what would your priorities be for this patient? You know, are you worried about, you know, obviously we don't have all the information, but are we mostly concerned about taking, you know, spinal precautions? Are we mostly concerned about his head injury? Are we mostly concerned about his fractured femurs and we need to splint those? Or the spleen where, you know, we may have internal bleeding? Are we going to start lines? We're going to provide him with fluid boluses to make sure his pressure is kept up. Just kind of think about the different priorities and the things that you want to do first versus last. And we'll kind of keep them in our back of our mind, and then at the end of this we're going to kind of revisit it and see what you think about those. So moving on, as I mentioned, when we started doing surgeries and having hypothermic patients done therapeutically, they noticed there was extra bleeding. So in 1986, there's a paper that was published by Valeri on hypothermia-induced reversible platelet dysfunction. It sounds terribly exciting, but basically they took a bunch of baboons, and on their arms they sunk their arms into ice water and they cooled the baboons' arms down. They then studied the bleeding time for a hypothermic arm, the arm that was cold and reduced to 27 degrees, and they compared that to the normal thermic arm. And what they demonstrated was that hypothermia played a role in altering some of the clotting factors, specifically thromboxane B2, which is what they were looking at in this study. They found that the cold arm had twice as long bleeding times as the arm that was warm. And they found that if they just took that cold arm that had been bleeding and then warmed it up, the bleeding would decrease. So it was reversible. If they were able to warm that arm and blood up, the bleeding would stop quicker. So that was kind of an interesting thing, and they found that the hypothermic baboons had worse bleeding times compared to the normal thermic ones. So that was really what came out of that study. But it got people thinking, We'll flip to the next slide there, Ryan. So with that one study, they recommended that prior to transfusions attempts, prior to blood transfusions, attempts should be made to normalize skin and wound temperatures. And then there's the next point on that slide there, Ryan. It would make me think, based on these studies, that some of the old first aid advice of putting ice or snow to cause vasoconstriction around a wound probably should be avoided, because based on this study and this information, we can actually make it worse. So from that kind of first aid and austere environment type of thing, we want to make sure we keep those wounds warm based on that information from 1986. So in 1987, after this published results on basically bleeding and hyperthermia, Djurkovic and some of his colleagues and a fellow named Luna and his colleagues kind of published at the same time similar findings on hypothermia in trauma victims. So Djurkovic published his that specifically looked at 71 traumatized patients that presented into his hospital. And he found that there was an increased mortality for patients with a core temperature of less than 34 degrees. There was 100% mortality for patients who presented with a core temperature of less than 32 degrees, regardless of their injury severity score. So it didn't matter how terribly injured they were. If they had a core temperature of less than 32, they had very poor outcomes, according to Djurkovic. Luna published at the same time, and he specifically looked at patients who came into the ICU, intubated trauma patients who were then presented into the ICU, who were severely injured, so they had an injury severity score of at least or approximately 33. But they found that 66% of the patients that came into the ICU, intubated after trauma, were hypothermic. So they had a core temperature of less than 36 degrees. Typically, the people who were hypothermic had higher trauma scores. They typically required more blood. And they basically found the majority of severely injured patients were hypothermic coming in. And they had a couple of thoughts of why this might be true. They thought that, a lot of these patients who came in who were intubated had been drinking. Alcohol was a factor. And they thought that that might blunt the vasoconstriction response. They also found that maybe the immobility from being on a spine board and those type of things increases heat loss and decreases heat production. They found that the injuries may impair the thermoregulation. And obviously evaluation and resuscitation and treatment may aggravate heat loss. So that was what Luna and his associates kind of thought why they might be hypothermic coming in. Just as a kind of an interesting thought. So they were the first guys that went around and started talking about this and generating interest. So this is just a quick graph on mortality rates of what Luna and Djurkovic found. Typically for the injury severity scores, what they were looking at, the mortality rate is less than 10%. So as soon as we see rates there of less than 34, and then obviously down to 32 for Djurkovic's study, we see mortality rates upwards of 40 or 50, 60%, which is 4 or 5 times as high as it typically is for a normothermic patient. So this really got a lot of people talking in the trauma surgery world. 30 years ago, these guys were on top of this, saying this is something we have to watch and we have to be very careful of. I don't know why we haven't seen it in EMS, but so we'll flip to the next slide there, Ryan. So in 1994, 7 years later, there was an article published in the New England Journal of Medicine, and it kind of talked about risk factors that increased your risk of hypothermia. And there's a big long list, but I kind of took some of those things out and just to talk about here. And really, there's lots of reasons. There could be insufficient fuel or hypoglycemia, impaired shivering, inactivity, acute spinal cord transection, just basically central nervous system failure or neurologic abnormalities. There's pharmacological causes, so paralytics and things like that. Any trauma to the central nervous system. Induced vasodilation from other pharmacological agents. just general exposure, cold infusion, so our IV fluids and blood and those type of things, environmental causes, multi-system trauma, and shock is a big one with acidosis. It's kind of identified as all factors that lead to someone becoming hypothermic. So if we think of that traumatized patient and we look at some of these things that may increase their risk of hypothermia, we're starting to kind of look at some issues here. So based on that list, we can cause hypothermia. We take spinal precautions, so the person is strapped down, they're not able to move, they're not able to generate as much heat. We provide them analgesia, which causes relaxation and things like that. Again, it resets or changes the ability to generate heat. Sedation, paralytics. They might obviously have alcohol or drugs on board with these traumas that are associated with that type of thing. May cause hypothalamic dysfunction, which is your thermoregulation point. It also may blunt protective vasoconstriction and shivering responses. So we look at the numbers basically. The first two studies that Jerkovich and Luna did, they were small numbers. I think one was 77 patients and the other one was 61. So it's really not a good number. It's not a good way of saying that, hey, this is something we need to look at. So through the 90s, there was a number of studies that were published that looked at this. So Rutherford published one on critically ill trauma patients and hypothermia, and he looked at over 7,000 patients in the ICU. A fellow named Martin looked at a study of a national trauma data bank of over 700,000 patients, and he looked at the rates of hypothermia that was presenting with coming in. Another one in 2005 looked at over 35,000 patients that were presenting in through a national registry. And another one in 2005 looked at 38,000 patients from a state registry that was coming in. So we now have some really, really strong numbers, and they all were kind of leaning the same way. Okay, well, just a question to you guys. Based on what the original studies found, what do you think these big trauma registries found?
Same kind of outcomes?
Yeah, so what kind of outcomes do you think they are?
High mortality rates would obviously the lower the hypothermia goes.
Yeah, that was a big one. Yeah, increased mortality rates. Okay, well, what we'll do is we'll move on, and if we can flip over there, Ryan, there should be a slide that has a whole list of things on it. So as we can see, the mean temperatures for survivors was about 34 degrees versus those that died was 33. There seemed to be kind of a point there in which the effects of hypothermia kind of maximized, and it was around 33, 34 degrees. So actually not all that cold. We found that the ICU lengths of stays doubled. One of the studies specifically looked at seasons in the Seattle area, and they found that there was no correlation in seasons when these patients would come through. They found that it did increase mortality, and that hypothermia is an independent predictor of mortality. So if their person's cold, their risk of dying is a lot higher than those who came in that were normothermic. And by pretty much all three of those, or four of those studies found that. And their recommendations were aggressive attempts to prevent and treat hypothermia were warranted. So we now have some big numbers. We got 6 studies, specifically the ones I looked at, that all show that we really need to be cautious of hypothermia in our trauma patients. So we're going to flip to Wade's slide here, and it's just a good graph demonstration. So the next slide there, Ryan, should be a graph. And we see on the right-hand side that normothermia, so 36, 37 degrees, the mortality rate is about 4 or 5%. As soon as they drop below 36 degrees Celsius, they kind of double their mortality rate. And then as soon as we drop below 35, it kind of goes up again, and it's 4 or 5 times as high. And as you can see, as we move down to 32 degrees there, it kind of plateaus around 50% mortality. So close to what Luna and Jerkovich was showing. except these guys never saw, you know, a 100% mortality rate that Jerkovich saw. But certainly, you know, there's a certain point in which mortality goes up. So these numbers are a lot higher than those numbers that we talked about with primary hyperthermia. So Ryan, we'll flip to the next page there. And recently, they're starting to look at kind of defining traumatic hypothermia. So where are the ranges that we should be concerned about in thinking this person's cold? And they're basically saying that normal is above 36 degrees. Ryan, you might just want to flip through all these and just put the whole slide up there. Mild is 34 to 36. Moderate is 32 to 34. And severe is anything less than 32. Now, we'll put up the accidental hypothermia numbers that we looked at before. And we'll notice that we're basically in the mild hyperthermia area for all of this stuff. So what we traditionally thought was mild hyperthermia could be moderate to severe hypothermia in a traumatized patient. So we'll kind of keep these new traumatic hypothermia stuff in mind when we move through and we talk about the protocols a little bit later. We'll flip to the next picture there, Ryan. This is just a dude hanging out on a rope in a crevasse. All these cold-looking pictures were taken up at Mount Rainier on a trip that another paramedic and I did a couple of years ago when we specifically looked at some of these topics. I just put them in there to make everyone feel cold. So 31st Combat Hospital in Iraq. Obviously we had a major conflict for a number of years, and unfortunately these conflicts create a lot of patients, but these type of conflicts have been, it's well known that major medical advances have been made in civilian medicine because of military conflicts. And the last conflict was no different. This particular hospital was looking at hypothermia, and they published their results in 2006. Arthur's was the lead author on that. But you know, we don't think Iraq is a cold place. They saw lots of trauma, and they were looking at these people coming in, and they knew that the bleeding rates were quite high, and they were losing a lot of soldiers to exsanguination. So when they looked at it, they demonstrated that about 18% of their patients coming in to their combat hospital were hypothermic. These patients presented with lower blood pressures, tachycardia, hypotension, and lower GCSs. They had lower hemocrits and pH with high base deficits. The hypothermia correlated with higher bleeding control surgery, blood administration, and factor 7A, which is a clotting factor that they were using overseas. They spent more time in the ICU, just like all the other studies, and they had higher mortality rates, just like all the other studies. And they were able to specifically target saying that penetrating trauma, a GCS less than 8, or any patients in shock, so presenting with a systolic blood pressure less than 90 millimeters of mercury, were all predictive of the patient being hypothermic. So if the patient was shocky or had a low GCS and they took their temperature, the patient would be hypothermic based on those other definitions, so less than 36 degrees Celsius. Severe hypothermia of less than 32 was very low in these cases, only 0.2%. So it was all those moderate to mild hypothermia cases, so the 36 to 32 degrees patients. And although there were only 18% of the presenting cases that came into that hospital, those 18% used over half the amount of packed blood cells, half the fresh frozen plasma. They used up 60% of the whole blood and 63% of the factor 7A used in all their bleeding control surgeries and in their resuscitation of these soldiers. So 20% of the population used half the amount of blood that they used while overseas. They found about a 40% mortality rate if the temperatures were above 33 degrees. But overseas in this theater, if you were below 33 degrees Celsius, you died. 100% mortality rate in their hospital. So we still have that 32 to 33 mark. That's quite a critical point whether you're going to survive or not. So we'll flip to the next slide there. So how did the Department of Defense respond? Well, they changed their TCCC, which is the Trauma and Casualty Care course. to improve their hypothermia guidelines in 2005. They put their hypothermia prevention management kits, were kind of become standard care for medics who were over there, and the military fellows all carry now because they've identified how serious this can be for a soldier who's obviously been wounded in battle. They've had a couple other joint things and things within the military, but they took it very seriously and put a lot of prevention measures in place to help improve the outcome for these kids. So this is another study that was published in 2011, and they kind of compared hypothermia and hyperthermia between military and civilian worlds, just to try and correlate numbers back and forth. And we can flip to the next one there just to show the numbers that come up underneath there, Ryan. But they looked about the same number of patients. They found the civilian patients had more hypothermia cases coming in by 2011 than the military did. So we would think that maybe the military were able to kind of start treating this and drop their number down to about 6% of those presenting who were hypothermic. Now, obviously, the theater in which they were looking at was Afghanistan and Iraq, where it was hot. So we see a lot higher number of the hyperthermia cases coming in to the military side of things. But I kind of wanted to include this particular slide because we'll go to the next slide there, Ryan. Because as you can see at this little graph, it looks similar to our last one. The middle low point there is normal thermia. And as we get cold on the left-hand side, the mortality rate goes up. But we see that on the hyperthermia side too, quite dramatically. If the patient's a bit warm, the risk of them dying is quite a lot higher. So although we're talking about hypothermia, I think the target for what we want to be able to do for patients is normal thermia in these trauma patients, and we're not overheating them either. Okay, we'll move on to the next slide there, Ryan. So a quick review, and if you guys have your speakers on, I'm gonna pick on some people. So let's see, consort there. Can you guys maybe tell me what are some of the causes of hypothermia in the trauma patient?
The environment that they're in, blood loss, trauma.
Yeah, well, good. Trauma's a big one. Basically there's many causes of it. Trauma being a big one, head injuries, immobility, all that stuff. But good. All right, Dennis, what's the temperature in which we say hypothermia starts in our traumatized patient?
Below 36.
Hey, perfect. Yeah, paying attention. Look at that. Now we're going to pick on Don in Brooks. Okay, severe traumatic hypothermia is less than...
Severe would be less than 32.
Right on.
30.
Perfect. Yeah, 32 is kind of on the definitions, but 33 was obviously what Arthur's was looking at.
Roger.
Yeah. Then, how about Deb down in Lethbridge? You get to answer the next two.
The next two? Oh, no.
Yeah.
Coagulation in the blood?
Right. And what happens to ICU and ventilator days?
Oh, they increase.
Perfect. Right on. Next slide there, Ryan. All right. In the matter of time, and because I've already picked on everyone, obviously their trauma patients' demand for blood goes up if they get cold. It doesn't make a difference on months of the year. It can happen anytime. They do not necessarily become hypothermic due to exposure to the cold environment. They can be in a warm environment and still get cold. Obviously, it is an independent predictor of increased mortality, and the effects may be altered by rewarming. We may increase survival rates once we warm them up. All right, next picture there, Ryan. So there's another one of my cold-looking pictures, but ironically, I'm sitting there with the white helmet. I'm putting sunscreen on because I felt like I was burning. But one of the things, as we've kind of identified all this hypothermia, and people like Arthur's who looked at other information, it was noted that pH changed and base deficit was different in these patients that presented as well. So is there more that's going on in these traumatized patients? And Hypothermia could increase acidosis. When we look at decreased perfusion, we get lactic generation. We have impaired hepatic metabolism and impaired acid secretion through the kidneys. So this increases, obviously, the acidosis in the patient. And then, we've looked at some other studies that look at the hypothermia and acidosis and the coagulopathy from that, and they've also found that hypothermia kind of seems to inhibit the fibrin generation at the initiation phase. So right when you cut yourself and the wound opens up, the hypothermia seems to affect that. But they found that acidosis kind of affects the thrombin generation at the propagation phase and increases the fibrogen breakdown. The acidosis acts on coagulation in a different area than the hypothermia. So they kind of, once you get both of these things, it makes your clotting factors even worse. So that moves us through to the next slide there, Ryan, which is the Triad of Death. So the pillars of the Triad of Death are hypothermia, acidosis, and coagulopathy. And if your patient has these three things, their mortality rate has been shown up to be about 90%. It's really, really bad. So now there's not really much we can do about acidosis or the coagulopathy in the field, but we can take away hypothermia, or at least prevent it. And we can do that very simply. We don't have to be an ALS truck. We can be, out by yourself in the backcountry. We can start looking at dealing with this and taking this whole section out of the Triad of Death. All right, so moving on. But with this Triad of Death, it's brought up something called, so let's flip through to the one called acute traumatic coagulopathy. And this is something we're going to see a little bit more in the future because these studies only came out in the last couple of years, I think 2012. And there's three studies that are on this slide from Davenport, Holcomb, and who's the next guy? Firth. Basically, they show that acute traumatic coagulopathy is changes in your clotting factors right from the moment of impact. One of the studies actually looked at, they had paramedics take blood as soon as they arrived at traumatic car accidents and things like that. And they found that 56% of patients had a change in their coagulation profiles within 25 minutes of the accident. So they're saying what they figure happens is you have this sudden deceleration in a car accident or during your trauma, and it causes micro tearing within the blood vessels in your body. The initial reaction with these micro tears is to start the clotting process. And so it all kind of clots up, and then the body goes, okay, well, we're not really bleeding out right now. And because it was a systemic kind of trauma, the body then kind of kicks into dissolving all those microclots. But this creates this big systemic clotting issues and coagulopathy. That's what they think. It's not great research right now, and they're kind of keeping their eye on it and trying to figure it all out. But hypothermia still comes into play in this because it's part of the Triad of Death. So I just want to put these up there because this is something we're going to see. This is something that's going to drive freeze-dried plasma and having plasma in the field and looking at massive hemorrhage protocols and dealing with those type of things in the pre-hospital setting. I think this is what's going to drive that. So this will be really interesting to watch in the future. So really this is how do we measure temperature in our trauma patients? And do you immediately take your trauma patient's temperature? To be honest with you, before I got into this, I hardly take a temperature anyways. It's in the protocols, and most of us do it because if we don't, the triage nurse will yell at us. But I don't know many people who would have a guy who fell off a motorcycle and routinely take his temperature as a first off thought. And I need to start trying to change that mentality. Unfortunately, what we have to take temperatures, for most of us, aren't really great tools for this. And that's something that, maybe needs to be discussed with, the bigger hires to be. But right now this is just an education thing talking about this in multiple environments, not specifically just AHS. So we'll flip to the next slide there, Ryan. And this was a guide that was put out by the Emergency Nurses Association out of the States. They looked at 36 different published research articles to determine kind of which method is the best way to determine, as close as we can to core temperature. And the next slide along there, Ryan, is a little blow-up of the ones we're concerned about. So they have oral, tympanic, and temporal artery. So most EMS units carry temporal artery. Some have tympanic, not many have oral. But they found that the only research under these papers that proved adequate comparisons between core body temperatures and using external sources was oral. And temporal artery and tympanic weren't recommended for adult febrile, and there wasn't really any other information for them to show for hypothermic patients or critically ill patients. So ideally, we should be taking esophageal, rectal, or then oral, which is the easiest route to be able to do. So in your little backcountry kit or whatever you're doing, a little oral thermometer for $12 you get from Rexall works really, really well. But we want to be taking temperatures no matter what, and using what we have on hand. So we'll move along to the next slide there. And what we have to be able to do in the field, though, is now look at some of the symptom-based determination for hypothermia, and that's how our protocols are written. The problem is alcohol and traumatic brain injury that cause this hypothalamic dysfunction may not cause shivering. It also might change the level of consciousness and things like that, so we can't accurately determine how cold they are based on those things. Or we may assume they have a TBI and they're actually hypothermic. There's also, those type of injuries can blunt those vasoconstrictive and shivering responses that give us those visual signs we'd normally use for an accidental hypothermia. Paralytic, sedation, those type of things also cause problems in being able to determine those things. This was just a quick article that was published last year, and it talks about basically taking wet clothing off of our patients. And they took a bunch of med school students, they put them in long underwear and stuck them in a freezer at -20. They wetted down their long underwear. And they gave them all a little army blanket and said, okay, sit there for 20 minutes and tell us how you feel. They then either gave them a vapor barrier, gave them a second blanket, or had them remove their wet clothing and sit with their single blanket. So going back to that study, basically they found that all three of them decreased metabolic rates, so they weren't shivering as much, they weren't using as much energy, which is important. But they found that if they just gave them a second blanket or a vapor barrier over top of their cold clothing, that those patients actually felt a little bit warmer. They didn't feel as cold. Now all three things are good, but what that tells us is we don't necessarily have to strip someone out of their wet clothing on scene or those type of things if we're able to adequately insulate them and provide them a vapor barrier, which is really easy to do. And just get them all wrapped up, and then their clothes tend to act a little bit like a wetsuit once we've removed that convective currents that go over top of them, and why a vapor barrier is so important. All right, so the next slide basically talks about treating our patients who are injured. So we moved on to these. I'm sure we all recognize this. This is the protocol for hypothermia within AHS protocols. And if we look through, there's no mention of trauma in here. It says, except in the patient safety considerations, right? There's a big box. And it just says, ensure underlying trauma is not present. So I'm not sure if this is supposed to mean that we do not treat hypothermia if there's underlying trauma, but it's something that we maybe should try and get clarified from our protocol guides. So it also mentioned that it's extremely difficult to obtain core temperature in the out-of-hospital environment. Obviously, that could be with the thermometers that we're using. There are agencies that use other thermometers that do get core temperatures in the field. But, you know, it goes through and it says, this is going back to that symptom-based stuff, it says mild hypothermia signs and symptoms describe all the drunks, right? Like every time you've been out. So slightly confused, lethargic, they make poor judgment, they have loss of motor consideration, ataxia. This is our list of people who are hypothermic. So these are all our drunks, and so any drunk that's ever hurt themselves is obviously hypothermic according to this. So it's definitely something we need to look at. And we've already kind of talked about the problems with this symptom-based hypothermia thing. So let's just kind of move on to our warming stages, active versus passive. Passive, obviously, as it states in the notes, we're just going to prevent further heat loss. So we want to cover our patients up, blankets, vapor barriers if you have it, it's really important. Warming your resuscitation room or the evacuator ambulance. But And then active rewarming involves obviously heat packs, warm IV fluid, humidified, heated oxygen, and then moving into bypass and ECMO and things like that. Okay, we'll flip through to the Kirkpatrick slide there, Ryan. And basically all this guy says is in his Canadian Journal of Surgery is that it's crucial to accurately measure the body temperature. Passive warming should be applied to all our patients, traumatized patients at the scene. We should obviously minimize extrication and transport times and make sure we keep our patient covered up at all times. It's kind of his big recommendations. So we talked about active rewarming and avoiding cold fluids, and we should assume that all our trauma patients are hypothermic and we should be treating them passively. So wrapped up, warm ambulance, all those other things that are in our protocols and talks about passive rewarming. And then those patients who are moderately or severely hypothermic, according to that, what I'm saying according to the modified scale, should get active rewarming. So patients who are severely injured and have cooled off to the point of 34 degrees need to have active rewarming, so hot packs and heating blankets and really aggressively starting to treat these patients. And I say if we get an accurate temperature and then we apply that modified traumatic hypothermia scale, these protocols still work, right? We'll say mild hypothermia, so anyone from 34 to 36 just gets passive rewarming. We just keep them warm, we prevent them from getting colder, and as soon as they drop below 34 degrees, we should be doing active rewarming. So interesting note, though, is the 28 degrees Celsius is the ambient temperature in which you take a person and lay them unclothed in a room before they neither gain nor lose heat. So most of our trauma rooms probably sit around 18 to 19 degrees Celsius. So unless the back of our ambulance is 28 to 30 degrees Celsius, which I don't think it ever will get, these patients are going to be getting cold when we expose them. We cut clothing off, we're doing other things, they're wet from blood in the environment, and we're not covering them up, we're not keeping them warm, we're making them cold. So although you think you have a warm ambulance of 22 degrees, that's not warm enough when we look at passive rewarming. They need to have heat blanket, or they need to have blankets on, they need to be wrapped up, and they need to have heat packs and stuff applied if they're hypothermic at all. And then realistically, with any of these patients that we're trying to rewarm, it's not really effective in an ambulance. I don't think any hypothermic patient we are going to be able to warm up with any of the means that we have available to us. What we need to do is try and prevent them from getting colder. We want to take them and say, you're 35 degrees, and I'm going to do what I can to keep you at 35 degrees, because that increases or helps with mortality versus letting you cool off to 34 or 33 degrees. So it's really important that I'm just trying to prevent them from getting colder and really being aware of it when these patients we're treating these patients in our ambulance. So Ryan, we'll just flip through to kind of some of the other means that we use to keep people warm. And there should be the first slide there of a silly space blanket. Now these space blankets, you know what, people have different opinions of them. They don't do much to, I think warm you up, but they are an amazing vapor barrier. And you can get the right size ones or two of them, and they pack really small in your pack. They can be stored on ambulances quite easily. And they really, that's the main point of what these things do, although they have some radiation. The big point is that these are great vapor barriers, and they can be easily stored. They're cheap as chips, so they can be put into kits and on our ambulances, I think. Below that is a sealed package, which is a ready heat blanket, which if we flip to the next slide there, Ryan, is a picture of. And they're kind of a 6 or 8 panel device. Stars are using these now. They keep these behind their stretcher and can add into their trauma patients, which they do routinely. And they're fairly small, and these are what are with the hypothermia management packs the military uses. And they're excellent. They're like the little hand warmers for your gloves, but they're body-sized. So you lay this on top of your patient on your stretcher, you wrap a couple thermal blankets around them, and we're going to really be able to start treating these patients properly. We'll flip to the next slide there, the hypothermia burrito wrap. This is obviously from a wilderness medicine specific setting, But we need to be thinking about this for our trauma patients. And now I know we want to expose and we want to be able to look at injuries and those type of things, and we can do that by exposing the specific areas we need. But to leave someone laying out with no clothes on because they were traumatized is not in their best interest. And we need to work around the inconveniences by having the patients wrapped up. But good insulation underneath them, wrapped around with a vapor barrier at the end there. The next photo is of the hypothermia prevention kit that the military uses. They basically have a sleeping bag with the silver blanket there, and then the heat pack inside and a little cap to help keep them warm. So these are all things that can be purchased or stocked from individual items, and it's something that I think we should consider for our EMS services in Alberta here. All right, Ryan, let's go to the last graph there. And it just talks about rewarming. And I just put this in here because it's a keynote to look at and remember that whenever we apply rewarming techniques, it's going to take time for our thermometers and our instruments to start detecting that the person's starting to warm up again. Especially, things like rectal thermometers that you cram in a big piece of poo, it takes longer for it to warm up. So expect that the patient's temperature could cool down before they start warming up. So don't be discouraged if you see that. It would be normal, and then just do what you can to try and keep that heat going and bring their temperature back up. So Ryan, let's just go back to our case study there of our 34-year-old male. And I want you just all to think again, did any of your priorities change when you look at this patient? Do you not cut all his clothing off? Do you, after you've, do you start doing hypothermia management before you do anything about the femurs? Do you, I just want you to kind of look at that and think about it, or are you just going to be adding in hypothermia treatment into that, making sure you get blankets on and heat packs and things like that into the areas you can while you're treating each of the areas. All right, we'll flip to the last slide there. Well, we'll say the last slide there is my advertisement, Ryan, for next year's conference, if you wouldn't mind. And then we have time for some questions.
Kevin, Dawn here in Brooks. I was just wondering, with your studies here, how effective are warm IVs in these patients?
Well, in BAF, we've been using our IV warmers, I think, because it's, honestly, if we look at someone who's 35 degrees Celsius and they're 70 kilos, a 1 kilo bag of saline, just, we look at the numbers, isn't going to be very effective in warming someone. But what it will do, it will help to say, instead of taking an IV solution that's 14 or 15 degrees, right, and having a 15 degree difference, we won't cool them off as much when we're providing these solutions. So having 1 or 2 IV bags up on the IV warmer for those patients that we're worried about, I think is a good idea to, again, help prevent them from getting cooler. Warming them up, it's not going to do much, but preventing them from getting cooler it will help. Any other questions? Comments?
It's Ryan here, Kevin.
Yep.
I want to say thank you very much. I think this is all really, really good information. I think in a lot of ways we're a little behind the times with the way we approach this, and you've touched on it, quite a bit in here that we're in the pre-hospital environment. We're extremely challenged with resources we have, ambient temperatures and the ambulance, our simple ability to measure patient temperatures accurately, which from where I sit, I think those are the main reasons we don't have more aggressive and stringent protocols on this. But I think it's good for all of us to keep in mind that we can all put more focus on preventing heat loss and trying to keep our patients warm and stuff like that. So I think it's really good information to know.
Yeah,
I think we'll. Oh, go ahead.
Yeah, I was going to say, I think if we just assume everyone is hypothermic when they're traumatized, and we're good at blankets and keeping them wrapped up and just really in the back of our minds trying to keep them warm, that the number itself doesn't really make any difference. That would be the big takeaway point. We don't necessarily need to know it. Ideally we should have it, but we should at least assume they're cold and just treat them that way.
Yeah, absolutely.
So there are all those studies at the back of my slides, which I think Ryan will have eventually up on the website. There's 4 pages of the references to the notes and stuff in those studies if they're interested to you. And then you can get a hold of me on email, Ryan, have contact or whatever, and if you have other questions.
All right. Well, thank you very much, Kevin. Does anybody else have any questions before we shut her down for the day? All right. Well,
Nope,
thank you very
thank
much
you.
for joining us, everybody.